Bueno, buenas noches a todos. Muchas gracias por estar.
Hi, good evening, everybody. Thank you for being here today. We're totally happy to be here with you today and to be able to have with us such speakers who are international speakers. We have today Dr. Wendy Levinson, and I want to thank her because this is a important decision in the international medicine studies, and to Dr. Bourne, thank you for being here with us. And she is collaborating with Choosing Wisely, and of course to Dr. Manuel Firaldo, who is a Colombian doctor working in Canada and who has provided all of the support to bring this app together. Thank you, Dr. Firaldo, and Dr. Abel Castaño, who is the brain and the mastermind after this project. He not only brought the idea, but also to wrote the reference document so that each society can create the project and its guidelines. And thank you to Patricia Torres, who is the executor, the one that is actually helping us to come up with these agendas. We all of us are totally busy, and she is totally responsible for helping us to be focused within the agenda. Actually, we just left the whole day to be able to be cohorted in the medical authority. Do you think this is familiar for us, the doctors? And we're also talking about to losing the medical professionalism, but without self-regulation, we cannot talk about the medical professionalism. And so the question I want to raise up today is, what have we done, the doctors in Colombia, to be self-regulated? So I always ask myself on how do we talk about the medical profession? And here is Ramon Bell with me. And he always told me, and how do we bring this back to reality? How do we implement the term of a medical professionalism? And thanks to Dr. Firaldo and Abel, we have this project ongoing, and doctors are self-regulated. We bet on the being a medical professionals, and on decision and choosing wisely, as the project is named. This brought up all of you, the member societies, to create this chapter in our country. And from this initial meeting, we will have 6 societies that show the interest, which are the pioneer societies, which have been with us developing all of these initiatives, which are the pediatricians, orthopedics, internal medicine, neurology, being this later 2, which are the ones that are much more advanced in the work in this sense. Today, we are processing 5 recommendations to be implemented in these pioneer societies, and that's the reason why we have provided the name of Choosing Wisely, Decisiones Acertadas in Colombia, following the guidelines at the international levels. This comes from the scientific societies from Colombia in the country, comes from us, and Dr. Castaño is the mastermind behind this. That is an initiative that should come from us, the doctors, to be self-regulated. These are 6 societies today, but we hope that tomorrow all of the scientific societies will be part of this. We will hope every specialty will be doing this process of self-regulation. We hope that every one of you today is an ambassador that promotes within your society to have the decision of choosing wisely, taking care of the knowledge, as we mentioned before. With you are starting a change process. We're building future, and a different future on which doctors can move from complaint to the action. We relate with the clinical evidence to provide the best for the patients and the system. And when we self-regulate, now we can have this medical autonomy to be leaders in our profession. Thank you very much. Great. So good afternoon, good evening, everybody, everyone that is with us today. Thank you very much. And for all of the attendees that are here today with us, and we hope that the audience will grow in the next minutes. For this event that I have the pleasure to announce today, I will have a presentation of the speakers that will be with us today. As you can see here, we have the participation of Dr. Wendy Levinson, Dr. Catherine Bourne, and Dr. Manuel Firaldo, who are part of the leader team in Choosing Wisely Canada and Choosing Wisely International. I will start with a presentation of introduction of Dr. Wendy Levinson. She's the chair of Choosing Wisely Canada, and she's also a professor of medicine at the University of Toronto. She is a national and international expert in the field of physician-patient communication, and she has led efforts to educate medical students, residents, and faculty members in patient safety, quality improvement, and the stewardship of finite resources. Dr. Levinson was part of the ABIM, the American Board of Internal Medicine, when the Choosing Wisely campaign was created in 2012. And another thing important to remember is that she is the main author of Understanding the Medical Profession, which is like a base text on the concept of professional medicine and what does it entails into our practice. So we are with a high level person, as Dr. Lina mentioned before. She's an international speaker, so to us is a reason to be proud, and we're totally happy to have her today here, not only in this webinar, but as well in all of the activities previous to the development and implementation of these initiatives of Choosing Wisely in Colombia. As well, Dr. Karen Bourne is the responsible knowledge translation lead for the Choosing Wisely Canada campaign. She is responsible for the dissemination of campaign content to patients and the public, and the integration of Choosing Wisely Canada into medical education. Karen also helps organizing the Choosing Wisely International a collaboration that supports other countries outside North America. She is an assistant professor at the Institute of Health Policy Management and Evaluation of University of Toronto, and teaches on knowledge translation, qualitative research methods, quality improvement, and value and sustainability. As well, we have today here the participation of Dr. Manuel Firaldo. As Lina mentioned before, he is Colombian. He completed his undergraduate studies as a bacteriologist and clinical laboratorian, and later his master's degree in health administration, both at the Universidad del Valle in Colombia. For more than 24 years, he has resided in the city of Toronto, where he has worked in 3 hospitals affiliated to the University of Toronto, and has completed several academic programs, including his CHE certification as a Canadian health executive by the same institute, by the Canadian Electoral College in Health. He has also been part of North York Committee of Choosing Wisely, part of the member of Choosing Wisely Regional Committee in Ontario, and active participant on the professionals in the clinical laboratory medicine that has been developing the Canadian Choosing Wisely recommendations for this discipline. In the last years, Manuel has been working with Dr. Levinson and Dr. Bourne in the dissemination of the campaign in Spanish-speaking countries, and he has been an important pillar when the start of the working in Colombia, with as long as with the Colombian Scientific Society, as well as with Dr. Lina Prada, and who's talking to you, Ramona Belcastaño. Welcome, everybody. Thank you, you doctors, Dr. Wendy, Karen, and Manuel, for your support and for your invaluable cooperation with the development of this initiative from its first steps. So I want to let Dr. Levinson to start Choosing Wisely International with the evidence on the impact around the world, and how to start on the professionalism and the medical field. Before starting with Dr. Levinson, I will show you how to use the translation icons. So down below, you can see the panel. If you want to listen to the interpretation, because we have simultaneous interpretation throughout the whole event, you can click on language menu down below. Here you can see this icon of a globe, and you can click on it, and please choose the language you want to listen to. It will be English or Spanish. If you don't do anything, if you just leave it on off, which is the determinate setting, you will always listen to me talking in Spanish or the doctors speaking in English. And if you want to join through your phone or iPad, you can choose the option to choose interpretation. You can click on these 3 dots that you have in your screen and plus, and you can choose the channel you want to listen to in the language interpretation, off to listen to both, or if you just want to listen to the translation, choose Spanish. Okay, so I think we hope that the translation will be successful and that we can be able to take advantage of these quite important information that Dr. Levinson, Karen Bourne, and Dr. Manuel Firaldo will provide to us. At the end of their presentations, we will have a discussion, a Q&A session, where we will have some of the questions you will share with us through the chat. And on top of that, we will cover some topics that we have prepared beforehand to discuss with the speakers. Dr. Wendy, welcome, and a warm greeting from Colombia. We hope that one day we will be able to have you here in a presential manner or virtually, if not presential, and that this great adventure and this great initiative that today we are reinforcing with our audience of doctors will have a really happy ending. And as we talked before, that we can be able to be the pioneers in Colombia and in Latin America as great disseminators of this initiative. Dr. Levinson, you have the floor. Thank you.
Thank you so much. I'm just delighted to be here, and I want to start by really congratulating you. You've begun a journey. You are leading in your country, and you will improve the quality of care for your patients doing this initiative. And then I think at the end, we can come back to the role you can play in the larger world stage in Spanish-speaking countries. So thank you for your beginning, and we are delighted to help support this. So I'm going to share a little bit about our journey in Canada, and I'll tell you that we also started small. So we started in 2014, and one of the things that helped us was that we published a report with 8 of the recommendations of choosing wisely that showed that in Canada, up to 30% of tests and treatments and procedures were potentially unnecessary. And this report, called Unnecessary Care in Canada, was really a bit of a burning platform. It created some interest and attention that this problem was true in Canada, not just in the United States, where we knew overuse was rampant. So we initiated this report to help us get the project going. And we created our campaign to really engage clinicians and patients in conversations about whether they needed tests or not, and help patients make informed choices. And so I want to just reiterate a little of the history. It did began in 2012 in the United States, and the American Board of Internal Medicine Foundation that created it is dedicated to medical professionalism. And really, I think the key thing to say here is that it is only we as physicians who can lead this conversation. If governments lead the conversation, or parties that pay for healthcare, their motive is really about reducing cost. And we felt that that would not be trusted by the public or by the profession itself, that really these conversations needed to be led by doctors who understood what was best for patients and could interpret high quality evidence. And so your leadership, again, is really key in your country, and it can't be done without you. Then we emulated this program. We brought it to Canada. We didn't take it just in the same way, because in Canada, our culture, our environment is different than in the United States. So like you, we then created our own recommendations. And now it's really in over 30 countries in the world, ranging from Australia, New Zealand, many of the European countries. Brazil has a fledgling program, and of course, the United States and Canada. And I'll talk more about the international work later. So the basis of the program in every country is what you're doing. Clinicians themselves, physicians, starting with physicians, creating lists. And this is the internal medicine list in Canada. We started with 9 societies, and we have the same as you, like don't routinely order CTs MRIs in the evaluation of simple syncope, for example. Or in an inpatient clinical setting, don't repeat CBCs and chemistry panels when a patient is stable. And often our societies, I want to mention, you know, they created 5 things. We were quite liberal about it, so some societies maybe only did 4, but many of them over time added to them. So we ask our societies to every year update their list to make sure that the evidence hasn't changed. Those that are still accurate just stay, but maybe with some new references. And then over time, many societies like this one, and I brought it up because it is internal medicine, they now have 11 things on their list. And so this does grow over time. And, you know, again, it is based, this is the foundation of the program, is the societies leading this work. And it has continued through the years to be the foundation. We see the societies as key. And so just to give you a sense of our journey in the last 8 years, we now have 83 professional societies involved, but we started with 9. And we have become multidisciplinary, which was always our hope. So we have nursing, pharmacy, dentistry, and other health professionals beyond medicine. And we think that's excellent and really is important because overuse and reducing overuse is really based on teams working together. We now have almost 500 recommendations. We're a big country and we have 13 provinces and territories, and we have a choosing wisely sort of office in each of those provinces that can tailor the work to their region. Karen will talk to you about the medical schools and also our public engagement work. But this is where we've come from in the last number of years. Now, I want to foreshadow what happens after you've created these recommendations, because it isn't just about creating the recommendations. After you've done that, and you could start to even think about it now, the question is, how do you put them into practice? I mean, raising awareness in physicians, writing articles in your field, running meetings like this, they're very, very important in the beginning, because you have to stimulate the interest in and recognition that overuse is a problem that's harmful to patients. But after that awareness comes the second phase, and that is really about implementing the recommendations. And so I'm going to talk a little bit about that too, so you can kind of see where this might evolve as your program matures. And what you see on this screen is toolkits that we helped people in our community create. So often hospitals like the one that Manuel's at created examples of how they reduced overuse. And we helped to package those into tools that other people could use so that they didn't have to start from scratch. They could learn from one another. So each of these toolkits, we have them in English and French, but you're welcome to use them. They're on our website, and they all give examples of why you should reduce that thing, what the evidence is, and then how you might go about doing it, and how you could measure the impact of it. So I'm going to share a few of these with you tonight. You can see, in particular, I'm going to talk about the reduction of blood use and also sedative hypnotics in older patients. But there are many on not using preoperative tests that aren't needed, not using Foley catheters, a nursing-oriented one, and reducing drugs like antipsychotics and proton pump inhibitors. But there are a variety of these. So here's some examples. During the early part of the pandemic, we understood that our donation rates for blood in Canada were markedly reduced. And even though there were fewer car accidents and surgeries, we were quite concerned about a blood shortage. And we had prepared a campaign on using blood wisely. And so what we did is we encouraged the hospitals in the country to measure their own blood use against national benchmarks. And if they could meet the benchmarks and stay and keep them for a number of months, 4 months actually, they could be recognized as a choosing wisely, using blood wisely hospital. And we have found that recognition for the work is quite important to our community. So in the blood program, we knew, for example, that red blood cells, and this is about red blood cells, not other products, are frequently overused. And that you could decrease them with simple measures. Simple measures meaning education, but most importantly, screening the requests for a transfusion in the laboratory when it came into the laboratory, so that the technician could see if it met the criteria that I'm going to show you for appropriateness. And if they didn't meet the criteria, the technician might call the nurse or the doctor and say, can we give 1 unit of blood and then reassess the patient before we give a second unit? And our toolkit was called Why Give 2 when 1 will do? Because we knew that you could decrease the use of red blood cell transfusions if you had certain benchmarks. And our benchmarks were that at least 65% of the red blood cell transfusions in a hospital were a single unit of blood. I often say that throughout my training, I never wrote an order for 1 unit. I always wrote 2 units RBC. And I learned that that was not necessary, that we could give 1 and reassess. And secondly, that red blood cells are not needed unless the hemoglobin is below a certain threshold. So we set the second benchmark as having at least 80% of the transfusions have a pre-transfusion hemoglobin of 80 or less, because the evidence strongly supports that patients with hemoglobins, unless they're actively bleeding above 80, do not require transfusion. So these were nationally agreed upon through a process I can describe to you later, and became the benchmarks for our hospitals. And we launched this in September, a year and a half ago, or a year and a quarter ago, just during the beginning of the pandemic in 2020. And we now have over 200 hospitals in Canada participating that give about 2/3 of all the blood. And you can see that over 80 hospitals have met this designation and can be called choosing wisely, using blood wisely hospitals. So this is an example of how we've tried to take these recommendations. I should say right at the beginning, there were many societies that had put using blood wisely on their recommendations about not transfusing when they weren't needed. So this program was built entirely on the work that you are presently doing. And you're free to take some of our recommendations if they're suited and use them. We offer them freely, but this was completely based on multiple societies, our hematologist, transfusion medicine, our internal medicine, that all had recommendations on this topic. I'll just give you one more example in Canada. We knew from our early research on that, in that article of that program I showed you called Unnecessary Care in Canada, that many Canadians who are over 65 were using chronic benzodiazepines or other sedative hypnotics. In fact, 10% of Canadians were on these drugs chronically. And we also know from the literature that they cause more harm than good. They lead to memory loss, car accidents, falls, and there's a lot of good evidence that senior citizens should not be on these drugs chronically. We again had multiple recommendations in our lists from geriatrics, from our long-term care physicians, internal medicine, that we should not be using these drugs. And so we have this toolkit, and we, one of our leaders did a study to show that this was in the hospital, and frequently in our hospitals, when people are admitted, there's an order written on admission that says that the nurse can give a sedative hypnotic at night, PRN, and often patients are discharged then on these sedative hypnotics, even if they weren't on them before. And so this study really was quite simple. They just did nurse education and they stopped those routine orders on admission of a sedative hypnotic PRN that was dropped from admission orders. And as you can see in these PDSA, Plan, Do, Study, Act cycles, that over time they consistently dropped the use of these sedative hypnotics. And this was done in multiple hospitals in the Toronto area. So again, I think one of the things that was really important about this is this was easy to implement, because changing routine orders is a pretty simple endeavor. Yes, you have to educate the staff that they have to help to support sleep in other ways, not interrupting the patient's sleep at night. They did, by the way, study whether this made sleep worse, and it did not. So they were not doing harm by stopping these sedatives. So I just want to go to the international community for a moment and tell you, as I mentioned before, that this really has spread around the world. There is a fledgling program in Spain. It's actually mainly in Catalonia, but it's in really so many countries now that have sort of adapted it and made it work in their setting. And, you know, before the pandemic, we used to meet each other once a year and really share lessons, but we do that now virtually, and Karen helps to coordinate that meeting, and you are more than welcome to join us when we have our next one. We will certainly let you know. But and here's one of our meetings, the good old days before the pandemic, when we met in Switzerland to have our international meeting. We have been working with the Organization for Economic Cooperation and Development. Now, I know that I don't think that Colombia is part of the OECD, but I wanted to show you that there's been this international interest in tackling wasteful spending in healthcare. This organization presents to all the ministers of health around these countries and did a report on this topic. And as part of this, they put together data that I think would be very interesting to you, and you might consider trying to do this inside Colombia or even across some of the South American countries. And what they did, and I apologize that I don't have your data on this, but they took different topics, in this case, antibiotics prescribed, and they've compared the use of antibiotics in multiple countries in the world. And what you can see is something you see everywhere, which is a lot of variation. So in this case, Canada does relatively well compared to the OECD countries. The average is in that orange bar in the middle, and Canada is a little bit lower than that. I can tell you that the Netherlands always does better than us. So we can look at this and say, what can we learn? And of course, at the other end, you can see that some countries in the world use a lot of antibiotics per capita. And so they can look at this and say, gee, how can I improve? What are other countries doing, and why are we an outlier? And this has been very helpful inside Canada too. We have looked at our different provinces and territories and seen a lot of variation, which you see inevitably when you compare. And we did that in the benzodiazepines, and some parts of our country use them in 10% of patients and other 25% of seniors. So I point this out. I'll give you another example, but it may be something you want to explore. So here is the use of advanced imaging, CT, MRI, and PET scans. And again, you see this enormous variation. It doesn't say what's right, but you can see that the United States and Iceland and Korea have extremely high rates of advanced imaging, and much higher than other countries in the world. So it does say something. Of course, we don't have exact differences in outcomes of patients, but in many of these countries, mortality rates are similar, and yet their rates of imaging is so much higher. I mean, compare Norway, for example, to the United States, and you say, what is going on there? There's some patterns of practice where we overuse. So you might look at this and think about whether you could do something inside different districts of Colombia, across different hospitals in Colombia, or potentially as you advance in working with other countries, compare countries in South and Latin America. I also want to give you an example from India, because I think this would be of interest to you too. Certainly Choosing Wisely started in the wealthy countries, but what has been interesting is to see it spread into low and middle income countries. And in India, there is a lot of underuse, as you would expect, where patients don't get what they need, but also overuse in sectors of the country and sectors of the population. And so with leadership of Dr. Pramesh, this program started in India, particularly in oncology, actually exclusively. And he worked with the National Cancer Grid in India to create a Choosing Wisely campaign and came up with recommendations. And what is interesting is that this is flourished there, but also he has worked with Sub-Saharan Africa. So now the collaboration is between India and multiple countries in Africa who have adapted this to their oncology situation. So I think the point here is that this transcends boundaries. We have overuse in many countries. As professionals, as physicians, we see the problem of overuse and the harm it can cause our patients. And you have the opportunity to develop this in your country, adapted to your situation, and also to potentially spread it. So I'll just end with a couple of suggestions of what you could do as societies. I think what you've already done is identified physician champions who can promote the message of Choosing Wisely, that we can improve quality and prevent harm from our patients by not always doing more, but choosing wisely and basing that on evidence. You could consider publishing your list in your own journals so that you disseminate them more broadly to your colleagues. You can do talks to present them to your colleagues. You can think of developing companion patient materials that go with the most common things that are on your lists. I would certainly encourage you to embed Choosing Wisely in annual meetings that you have in your country, so you can disseminate them and engage your colleagues in creating new recommendations or advancing this. And you can consider right from the beginning how you might work to promote implementation of one of these. We didn't do that in Canada. We did it sequentially, but I think if I were starting over, I would kind of think of something very important, maybe antibiotic use or something very relevant in your country, where you might start thinking about how could we change this right from the beginning. So I'll end to just say, we realize that overuse is complex. Reducing it requires patients, physicians, and other healthcare professionals, and health system leaders who can help support, build an environment that helps reduce overuse. It is absolutely based on physician leadership. So again, I thank you and congratulate you on the work you've already done. Karen is going to talk about the training of students, which we think is very important. It really is a culture change. And so I want to say that you do have an opportunity in South America and Latin America, but culture change takes time. So be patient with yourself. It is a journey that you're beginning. It's one that I think is very intellectually stimulating because it's important. It allows us to be real leaders in our profession, but it does take time. And so I would encourage you to see it as a marathon, not a sprint. And we will certainly be eager to watch and to support you in any way we can. So I'll stop there, and I think we can take questions whenever you would like to do that.
Muy bien. Muchas gracias, doctora Wendy, por su interesantísima presentación y la visión global que nos ha dado acerca de esta iniciativa y la experiencia tan interesante que ha ocurrido en esos países.
That has occurred in these countries that you have mentioned before. So we hope in the next presentations we can include the Colombian flag as well, and many other flags of other South American countries as well, and from Latin American countries, of course. And well, I would like to add something to your presentation that we can later on discuss during the discussion and Q&A session, which is about the process of implementation. We have been thinking within our project that once the societies, the scientific societies, and those that are pioneers, which are the 6 that Dr. Triana mentioned before, have published their list of their 5 recommendations on the medical behaviors that should avoid. Each recommendation, we will hope that it will be at least tried in one hospital or in one either a hospital or outpatient center, and maybe they try it out with a pilot, probably having the methodology that you have shown before using those cycles that we call PHBA in Colombia, which is planning, acting, verificating, and acting again. And this easy methodology can tell us the impact that it may have these initiatives on the practice scope. But maybe this is another question for the discussion session, but maybe I want to do it once again, is that maybe you can tell us, and maybe the other speakers as well might tell us, and what are the suggestions that you can provide as experiences from other countries that has allowed them not only the implementation on the pilot trials, but as well to scaling up and how to adopt in general for the whole medical community in such countries. So this will be an open question for later on, and that later on we will check on during the discussion session. However, thank you very much, Doctor, as well, of course. Please, we'd like you to be in the discussion sessions. I know you will be for a few minutes away, but we will have you later on during the discussions from 8:30. So now we're moving on with the presentation and the agenda we have today. And for our next presentation, we have Dr. Catherine Bourne, that I was previously introduced, and she will be talking to us about on how to implement the new Choosing Wisely initiatives, particularly regarding the challenges and the lessons learned from those, from the implementation and the involvement of the engagement of the patient groups and the professionals. That is the topic that we will be covering with Dr. Catherine Bourne. So Dr. Catherine, you have the floor. A warm greeting from Colombia, as well as I told Dr. Wendy, I hope to have you here with us soon in a presential manner.
Thank you. Thank you so much for the very warm welcome and for the invitation. And it's really been a pleasure to be here this evening, and I look forward to the panel. So buenos noches, everybody, and let me go over the objectives for my presentation. I have 2 main areas that I'll be covering. The first is on how we engage the public, members of the public in our campaign, and also on medical education. I'm going to be sharing approaches to awareness raising for both those 2 groups. And then I also am going to be similar to what Wendy did, offering some examples, global examples of approaches to patient public engagement and medical education associated with Choosing Wisely campaigns. So first, I will begin with medical education, and I'm going to share with you our program. Our program is called STARS, which is an English acronym, Students and Trainees Advocating for Resource Stewardship. I looked up the word for STARS in Spanish. I think it's Estrella, so I apologize if the pronunciation is not right. So I think we'll have to work, should you choose to move forward with medical education, on a punchy short acronym. for the Colombian context. I'll briefly describe this program and share some examples of its impact. And then I want to tell you a couple of stories too about what our students have done in Canada, give you some examples of Canadian students and their leadership, as well as internationally what student leadership has accomplished, and share a little bit about our pandemic adaptations of the STARS model in Canada. So this is a photo from an in-person meeting of our STARS student. What STARS is it brings together two early year students. We have 4-year undergraduate medical education programs in Canada. So we want to reach students at the beginning of their training. And we have 17 medical schools across our country. So we bring together 2 students from each of the 17 schools, and they really form a community of practice across the country where we tell them it is really up to you to do what you feel most suits your local school context, but what your goal is to really raise awareness about resource stewardship, about choosing wisely, and really raise awareness among their classmates, and also to help to embed resource stewardship into the curriculum. Again, really following very much from what Wendy spoke about. We know that choosing wisely as a model of change is not a top-down model of change, but rather a bottom-up grassroots model of change. So we wanted to adapt that to the medical student context and say choosing wisely should be introduced in medical school curricula, not through the faculty, but actually by the students themselves. So really taking that grassroots model. And what our 2 students do is they lead interest groups, clubs, and really become leaders within their own school community for choosing wisely. So here's some nice photos of our students. These are 4 meetings that were held in person from the years 2015 till 2019. So these are all of our students gathering. The students in that top corner from 2015, many of them are now practicing physicians. And to date, because we have 17 schools with 34 students each year, we've had over 150 students participate in our program. And so we like to think about this as really a multiplier effect, where we're training individuals who are at the beginning of their career, and now many of these people are out in practice, and in fact, many of them continue to be choosing wisely leaders across their various fields of specialty. So we did adapt our program to a virtual model. So this is a screenshot. We managed to have fun on Zoom with our students. Here's another picture as well. And in many ways, the virtual model has been quite useful for our students. Canada, as you know, is a very large country. We span 5 time zones. And typically our previous model involved students attending our Choosing Wisely Canada annual conference, as well as attending a day-long meeting where they learned about resource stewardship, where we brought in speakers, where we gave them fundamentals associated with choosing wisely. But what we've adapted of our program to become is more of a longitudinal model. So we bring in the students usually on a monthly or bi-monthly basis. We have shorter speakers for them. We can bring in speakers from across the country, and we have more opportunities for interaction with them throughout the year rather than just once a year event. So we have adapted using Zoom and other virtual approaches. And this photo in particular was a social event that the prior year's students held for the current students, that brought them together so they could have a little bit of fun. So we have been tracking our student accomplishments and have published about this. This was a paper that was a descriptive evaluation published in the Canadian Medical Education Journal just after 6 months of launching the program. And what we wanted to do was get a sense of what the students were doing locally. So many had launched interest groups, had become involved in curricular change. Many were hosting special campaign weeks or other special events or presentations at their school. So these are just, again, a couple pictures to show you what the students have done. That picture in the middle was some students developed a fridge magnet for other people in their class to take home, or brought in leading physicians to come in and speak to their class over lunchtime. So again, this has adapted and grown in some ways because of the virtual model, but also many of the prior activities continue. So I'll start from the top, where students have interest awareness weeks about choosing wisely. So this image is a poster that just happened earlier this month in Quebec. It's in French, it's our French-speaking province in Canada. And the students there collaborated across the 4 medical schools in that province to offer conference presentations. They had a prize and, they made a game from it to really incent other students to join, and really offered an opportunity for extracurricular learning through this week-long event. Other students have held events and virtual conferences. So those are some posters from those conferences, again, bringing together students with workshops and other, again, extracurricular education, because this is typically, sometimes not embedded in the curriculums yet in our medical schools. Again, we have examples of interest groups where students have a club and they bring together students across various groups to work on, on choosing wisely activities and events. And I know in Wendy's presentation, she mentioned the choosing wisely work in Brazil and in Africa. And in fact, sometimes at our medical schools, the interest groups will work together. So a global health interest group and a choosing wisely interest group at one of Canada's medical schools next week are hosting a presentation on global health and oncology and the role of choosing wisely, featuring a speaker from Rwanda and a speaker from Brazil. So really, again, giving these students an opportunities to lead and to work together to do what is most relevant in their context and what's of interest to them as well. And then lastly, the students are involved in curricular change. So again, leveraging this grassroots model, the students will go and speak to their Dean of Education, for example, and say to them, here are some ways that choosing wisely content or choosing wisely skills, such as shared decision making or topics like antimicrobial resistance, can be integrated into our curriculum. And so this is just an example here from the University of Manitoba in terms of how they mapped their curriculum and choosing wisely. Now, I want to just do a spotlight, as I showed you a lot of photos of bright young students, and this is one student. Now she's a physician. She's still a trainee in obstetrics and gynecology. This is Dr. Catherine Friedman. She participated in our program in 2016, and since then has really had, I would say, specialty specific leadership associated with choosing wisely. So I have a screenshots here on my screen of a commentary article in the Journal of Obstetrics and Gynecology of Canada, which she participated in. She's the last author there because she helped the Society of Obstetricians and Gynecologists of Canada to develop their list of recommendations. She did a lot of the research behind it. During the pandemic, she developed a statement about resource stewardship specific to obstetrics and gynecology during the pandemic, some of the rapid changes to practice that happened as a result of the pandemic, and suggested some challenges associated with that, as well as some benefits, and offered a resource stewardship lens on a rapid shift to virtual care, in particular in obstetrics and gynecology. And most recently, because Catherine has an interest in fertility, she's been involved with a group from the Canadian Fertility and Andrology Society in publishing their list of recommendations. So this is a tweet from January where she says she's so excited that this publication is coming out. And again, she was involved in that as an author. So what this story of Catherine really offers is that participating in choosing wisely as a student offers students an opportunity for leadership within their own specialty and offers them an opportunity to explore what their future career may look like. Initially, when I met Catherine, she wanted to, be an obstetrician, gynecologist. She's now shifted into fertility as an interest, but she brings choosing wisely with her across that. And she demonstrates her leadership to senior physicians in her field by participating in choosing wisely initiatives. So STARS is not just in Canada, and that's why I was thinking about the Spanish acronym, because STARS has spread around the world. So on my screen, you can see photos of the student interest group from Japan. They published a textbook related to choosing wisely in Japan. In the center of my screen, you see the map of the United States. And just recently, a couple of weeks ago, there were over 100 students who participated in a virtual leadership summit for STARS across 50 medical schools in the United States. And then this last photo is a group of medical students in Amsterdam who also have a STARS program and who I had the privilege of doing some teaching with when their program launched. And we have also published about this in academic medicine. So at the time that we published, there were 7 countries that had similar student or STARS campaigns or campaigns associated with choosing wisely. And since the time that we published, Brazil has also launched their STARS campaign. So I've added that image there to the map as well. And they're very engaged and come to our meetings, and a real pleasure to work with the students of Brazil. And so next I'm going to move over to patient engagement in choosing wisely. So I have 3 objectives here. The first is to share the importance of shared decision-making with patients to implement campaign recommendations into practice. The second is to offer approaches to patient and public engagement that choosing wisely campaigns use and might be of interest to you folks in Colombia. And then lastly, to really give you 2 case studies of how patient and public engagement is embedded into our work here in Canada. So there is a lot of evidence to show that engaging patients in shared decision-making improves patient outcomes. There are systematic reviews and Cochrane reviews on the subject, and there very recently was a systematic review and meta-analysis. It was published in 2020 around engaging patients in de-implementation interventions specifically. And the conclusions of the review show that shared decision-making and patient education can reduce low-value care. So while often, patient engagement or shared decision-making is seen as a soft skill for clinicians, there is hard evidence and data which shows that it does drive improvements to outcomes. So corresponding to choosing wisely recommendations, we do offer patient information. So that's really plain language, easy to understand information that a doctor can open up in their office and talk through a clinical problem on with a patient, or a patient can access themselves. This is all available on our Choosing Wisely Canada website. And we also have a simple tool which we adapted from our colleagues in the United States, and which we've shared with our clinicians. When we first launched our campaign, we actually printed out tens of thousands of these posters and sent them to family doctors across Canada. There's about 30,000 family doctors in Canada, and we mailed these posters to their office and said, put them up on your wall in your exam room and show your patients that you are open to having conversations with them about choosing wisely. And so they're very simple conversations to help start, very simple questions, pardon me, to help start a conversation about whether or not a test, treatment, or procedure is needed. And we do try to make our information stand out and be very memorable to patients, because the idea that more medicine isn't always better goes against a lot of the culture that people expect from medicine. We expect to have that pill that's going to make us better. We think getting, more tests and treatments is going to help our health. We don't think it could harm us. So we try to explain this in ways that are creative. And I wanted to show you some examples of that of colleagues around the world have used. So this pink poster is a cactus being watered, and too much water will kill your cactus, and that's from Brazil. So again, using the same language of more is not always better. This middle one is from New Zealand, and people in New Zealand and Australia love to travel. So showing that an overstuffed suitcase, you won't be able to, fit everything in when you travel. So again, more isn't always better. And the same is the case when it comes to medical tests, treatments, and procedures. And then lastly, this last one is from Norway, from the Norwegian Medical Association. And they eat a lot of porridge in Norway. And this is pouring too much cinnamon on a porridge. So, too much cinnamon isn't going to make your porridge taste good. Really trying to make a very clear, easy to understand way for the public that more medicine isn't always better medicine. And also our 4 questions have been translated. This is a Canadian example because we have such a diverse multicultural country where people speak many languages, but also it's been used, the middle posters from Wales, and then another example of the 4 questions in New Zealand. And now I have 2 case studies that I'll briefly walk through. The first is our Opioid Wisely campaign. As Wendy mentioned, there are a number of really high yield overuse priorities associated with choosing wisely, where we know many of our societies have recommendations on this topic. So I wanted to again show you data. I know Wendy showed data as well from the OECD on the volume of on a quality measure, so volume of opioids prescribed to the adult population, and then proportion of chronic opioid users, with opioid use being a very harmful and difficult overuse issue in our country that does lead to significant harm to patients. So we have a campaign that brings together over 30 societies to really share this message that, to avoid unnecessary opioid prescribing. So I wanted to share an example where patients got involved. So this is a recommendation from the Dental Society. Again, as Wendy mentioned, we don't just have physicians involved in choosing wisely. So this recommendation is to not use opioids for post-operative dental pain until non-opioid analgesics have been optimized. In Canada, our data shows that about 20% of community opioid prescriptions come from dentists after surgery. So this is an email that I received from a patient advisor who works with Choosing Wisely Canada. Hopefully you can read some of it in English, but she tells me the story that her 16-year-old son had wisdom tooth removal, and she was offered opioids, and she knows our Choosing Wisely recommendations. So she engaged in shared decision-making with the dentist and the dental assistant and said, I don't want my son to have opioid medication. I'd like to have something else that is a non-opioid pain medication. So we took this and her individual lived experience as an opportunity to actually write an article that was in our national media. She co-wrote it with Dr. Sutherland, who was the dentist who led our Choosing Wisely list. And this article was published all across Canada. Wisdom tooth removal is a very common surgery in teens and young people, and opioid abuse is also very common in young people. And this story of how the parent intervened to avoid that initial prescription was very powerful and read across our country. And so we use the media to amplify our message here and to really share. We know how powerful stories can be, so we wanted to share that story. And we also developed, as with other Choosing Wisely campaigns, posters, as well as plain language patient information with our partners. So these are just some examples, again, of some of the tools for shared decision-making with patients that we've worked with our partners on related to opioids and dental care specifically. So the second case that I wanted to share with you, where we've engaged patients in our campaign, is around using antibiotics wisely. Again, showing you data from the OECD, showing a lot of variation in terms of overall volume of antibiotics prescribed, but showing as well that Canada, while just slightly below the OECD average, still prescribes a significant amount of unnecessary antibiotics, and particularly in the community setting. We live in a cold climate, so we do have a lot of people coming in for cough and cold and upper respiratory infections to their primary care doctor. So we really targeted that, in particular the community prescriptions of antibiotics for this campaign. And what we wanted to do was draw on a significant evidence base of tools to work with patients and to engage with patients and do shared decision-making to avoid those antibiotic prescriptions, because we know that really it involves a lot of shared decision-making for the clinician in a primary care setting, typically, to tell their patient, you don't need an antibiotic, but here's what you can do to feel better. And so we've also adapted those tools in COVID-19 and really tried to share those tools with primary care providers, with family doctors. So that is our Using Antibiotics Wisely campaign. So this is a poster, again, that we share with our family physicians, and then also a delayed prescription, which is an evidence-based approach where a patient comes and says, I have a cold and my chest is tight, I need an antibiotic. And the doctor says, I do not believe that this is a bacterial infection. I've listened to your chest, it is clear. And so instead, I'm going to give you a delayed prescription. You can fill it if you, if you're still not feeling better, but I'm quite confident that you don't need an antibiotic. And then the other tool that we've offered is a viral prescription pad. Again, for something like an ear infection or upper respiratory tract infection that is viral rather than bacterial. And so in that case, again, offering symptom management approaches. And then again, we like to work with our media partners. So this is an article that was written by two physicians infectious disease specialist and a family physician about managing cold and flu season with COVID-19, really speaking directly to parents and to members of the public through the media, and really leveraging the media's reach to get our message across that an antibiotic will not help you and that there are other ways to manage your symptoms. So this is my last slide. Just to sum up my presentation, both on our medical education activities with Choosing Wisely, as well as our patient and public engagement activities, which I hope demonstrate that Choosing Wisely is really a grassroots clinician-led approach to changing culture. And to change the culture, you need to start from the bottom up and begin with trainees and really help the next generation to get engaged in this campaign very early, because it can help to shape their career moving forward. Choosing Wisely, again, being about culture change, needs to work directly with patients who are so much a part of our medical culture, because they shape the demands and their demands and expectations shape how clinicians interact with them. And by offering tools and materials for shared decision-making, it can make that easier. And also, there can be creative approaches to raise awareness about Choosing Wisely. Some of the posters that I showed you, for example, or work in the media can really help to raise awareness with the public that more is not always better. So here's my contact information and my Twitter, and then I will stop sharing my screen and look forward to the panel discussion. Thank you.
Muchas gracias, Karen, por tu excelente presentación. Creo que nos has ilustrado con hechos reales cómo es de importante.
Well, I think that you've really showed with examples from the real life how important it is to involve in this process not only physicians but also students and patients, because the audience in general, the population, is a very important, it's a key part of overuse or in overuse and over prescription and over treatment. And you've really given us really interesting examples, and you've given evidence that this involvement of patients and the public in general is really important. I would like to tell you before we go with our next panelist, to most of you who are in the audience and don't really know what we've been working with this Choosing Wisely initiative. In broad strokes, what is it? What is this initiative? It's an initiative that was born in the United States in 2012. And at the moment, what they did is that to each medical association to create a short list of 5 recommendations of physicians' conducts that shouldn't be done because there's evidence that they might be harmful, they might be damaged, that they're wasteful, or that they're useless. So doing that exercise, the medical scientific associations started to publish this short list of recommendations, and everyone wanted to do their own exercise then in Canada and the rest of the countries that Dr. Wendy was mentioning. Here in Colombia, we started this effort 2 years ago, thanks to the efforts of Lina Triana, who's chief of the Colombian Association of Medical Societies. And we were using the same guidelines of Choosing Wisely International, which is precisely the team that is led by Dr. Wendy and Dr. Manuel and Dr. Karen are part of. Here in Colombia, in spite of many countries adopting the name Choosing Wisely, other countries gave it another name. And here in Colombia, we decided to title it in Spanish. That's why we're calling it Decisiones Acertadas, or right decisions. And it has a motto that it's caring from knowledge. And this image, these colors were product from a research that a very intrinsic detail from an advertising agency that explored from the medical area all the expectations, all the perceptions of overuse, overdiagnose, overtreatment. And this is why the Colombian Association of Scientific Societies decided to take this name, Decisiones Acertadas, Caring from Knowledge. So those of you who are familiar with the Choosing Wisely name, you know that now that our name or that name here in Colombia will be Decisiones Acertadas. Today's event is basically aimed towards physicians, to medical associations, scientific societies, and associations, because what we want to do here is just to let you know what is this initiative, how does it work around the world, who are the leaders, and in a few moments we will be talking with Manuel, so that all of you can understand that this is a very important initiative at a global level, and that these 6 pioneer associations in Colombia that are working here are being pioneers of an experience that's been extremely relevant at a global scale. We're going to have a launch event for the media, for the public in general, the 5th and 6th of May this year. So very soon from the association, you will be receiving all the information or the event, how to connect, how to participate. But this event that we're having today, it's, let's say, a preliminary event, so that you as members or as physicians can start advancing with this initiative and just get motivated and see that this is a global phenomenon. So now I'm going to give the floor to Dr. Manuel Firaldo, who is going to talk about the real life experience of implementing Choosing Wisely initiatives in Canada. And welcome, Manuel. I know that you live in Canada, but this is your country. So we hope that one day you can join us again here in person. So thank you, Ramon. Good evening, everyone. Thank you for joining us in this very important event. With this campaign that we're starting to implement in Latin America, and hopefully in the future, many more countries will join. First of all, I would just like to do an echo on the comments from the comments of my two previous colleagues that talked. And I just wanted to congratulate you, Ramon, with the leadership that you've shown with this initiative. I know that you've always had a lot of energy. You put a lot of effort into this. And when I heard that Linea Triana was going to be the chief of the Association of Colombian Scientific Societies, we knew that this was going to be become a reality. So thank you very much to you two, to you, Ramon and Lina. Thank you to all the physicians and medics from these 6 pioneer associations. And I would dare to tell you that for me, it's a privilege to be here tonight with Wendy and with Karen. Wendy's experience is amazing. It's from the inception of Choosing Wisely, and Karen has been a tireless leader. Every week I read something from her. She has basically every week she has a presentation and discussion, and she's always has a lot of energy, and she's always helping everyone. So thank you, Wendy and Karen, for joining us. And here tonight, I just want to talk about the experience at a hospital level, right? So we've heard about a global level with Wendy. We've heard about the work with students all around the world from Karen, how to engage patients, and I'm going to talk about how can we land those things that Karen and Wendy have talked to, and land that in a hospital. How are we going to ground it in a hospital where we really need to implement those recommendations from the associations? The first thing I want to say, which Wendy mentioned, and I would like to invite you to think on this, the first recommendation is that this must be multidisciplinary effort, because this initiative started with the idea that everyone needed to participate. It doesn't matter if they're dentists, if they come from, if they're they work on labs, biochemists, pharmacologists. it's important to have their consideration. And it's also, the second thing is to, what Karen was mentioning, that the participation, the engagement of students and the academia and the patient is key for success. So I'm going to step out a little bit of the theory and I'm going to ground it in a more practical examples. So with all those concepts that Wendy and Karen have talked about, I'm just going to talk about experience. From my experience here in Canada, I've worked with very important hospitals in Toronto, and I'm very, very proud of the work that I've done, and I'm very glad. So here, my latest experience was with the North York General Hospital. It has over 450 beds, 12 surgery rooms, 21 intensive care unit beds. Annually, we'll have 145,000 visits, outpatient visits. And this experience is from, I've had this experience since the Choosing Wisely chapter, Canadian chapter was started. In 2014, in June, when the campaign reached Canada, some hospitals started to implement it. North York General Hospital was one of the first one to implement the campaign in June of 2014. And we have already been working with electronic orders, and this really helped us to become really successful so that we could work with physicians it was really helpful in introducing those recommendations. And what happened next is that we started delving deeper into the campaign. And now, Ramon, these 6 associations that you were mentioning, these pioneer associations, they're going to start releasing these recommendations, and the hospitals are going to need to know which are the steps. And my intention is not to plant a single route. I'm just going to tell you about the experience of someone who has worked with in a hospital and that started really early in implementing these changes, together with the Choosing Wisely Canada team that was being led by Wendy and Karen at the time, but with hospital leaders.
Entonces,
and in 2014, when we started to implement the campaign, we already had a strategic plan, right? So in this hospital, it's very normal to have a strategic plan every 3 or 4, 5 years. Within that strategic plan, we obviously had as a big concept the proper use of resources. That means usage, and I think we always have that we always consider that. So once the campaign was started, we saw that the campaign would help us lead, or will help us reach those goals that we had. And we were going to improve the quality of the service, and we will also help the patients, the quality of care of the patient. So we designed a strategy so that the campaign would be successful. Here on the screen, you can see that the strategy that was started in 2014 and was created in conjunction with the director of the committee, launched the strategy, and with the leaders from the different departments, from the different services, X-rays, labs, emergency, oncology, all the leaders got together and started looking for the best strategy, for the most successful strategy. And we created 4 pillars. They go hand in hand with the guidelines of the Choosing Wisely campaign. So first is the commitment of the leaders. The hospitals will have a MAC committee. That means the quality committee directed by the physicians. The chief's committee, we needed the commitment from all the leaders in these different committees. So our campaign was aimed towards that leadership becoming part of this system that we were trying to implement. Our strategy obviously also included something that Karen mentioned a lot, which was patient engagement. and involvement, not just the understanding on how to educate the patient, and why some procedures that can be harmful rather than beneficial. So we needed that the patients become active participants of our discussions so that we could be able to tell them we're thinking on eliminating a certain test here or there, and hear from their point of view what would be the ideal way in which we could use those leaflets, those posters. How can we present it to other patients so that they could start that dialogue with their physicians? We started with educational campaigns with the patients. We aim all of our efforts always to keep the patient at the center of the care. We also worked a lot in generating and assessing ideas. So we're talking here at a hospital level. We talk with the different chiefs from the administrative area and from the different medical services to start generating ideas and seeing which of those recommendations that we could find in the list that we had access to, which of those recommendations could we start implementing in the hospital? Which ones could we prioritize, right? And which others have we already been working on? Because the idea was to implement ideas and see what had been our progress. How far were we? Always always considering the scientific evidence, right? So we review all that material and I'll show you the outcome from that work. And finally, we did a marketing campaign where we used screensavers in our computers. The director of the Choosing Wisely launcher blog in Twitter, and where she was teaching all the community of the hospital of the campaign and all the benefits that it could bring. And we also work with different departments and different sections. All this was based on the Choosing Wisely principles that we previously saw. So the committee has always been multidisciplinary. So this committee is led by the director, the chief, the director of the hospital. She's the VP, but at the same time, she's a surgeon and she has a direct contact with patients. And at the same time, she uses a co-director who is the administrator who will help her navigate within the administrative and logistic decisions and the impacts that they have. So we invited key leaders from areas that where most procedures were being used, most lab procedures, medical procedures, and we obviously involved pharmacy, pediatrics, and all the leaders from all those different services were key. So we invited them to analyze those recommendations and see how they could start implementing, what were the priorities. And we obviously also invited the administratives, the key administratives from those areas to bring support. So we had marketing within the hospital, the communication department, the quality department, the decision, the support decision department, all the data that was being analyzed to see if they had a negative impact or a beneficial impact for the patients. And obviously the patient had to be at the center of all of that so that they could give us input on all those decisions. They could give us input on all those decisions. Now, there were different interventions. The interventions of Choosing Wisely go to procedures, treatments, medication, x-rays, labs, and many other sections. As Wendy was mentioning, there were over 500 recommendations that you can find in the Choosing Wisely website that are available for anyone who wants to know more of them. And there are over 80 associations that are members of this initiative that started with just 9, not only medical associations, but from other areas such as infirmary, dentistry, pharmacy. And I would like, my specialization is a clinical laboratory. I've been working all my life in this area. So with a little more weight, talk about my experience in this area. But I also wanted to tell you about the work that we did when comparing with other areas in other hospitals, because you can do it as well. So the clinical department, the lab department of the North York General Hospital is a medium-sized lab compared to the hospital, to the clinical labs, where we can process around 2 million tests a year. We have over 21,000 pathology cases. We have 100 people working in the lab. And I would like to just, we're acknowledged at a regional, national, international level because of the practices that we do in genetics, in oncology, and other areas. We also have, we knew that that strategy had been in place at a hospital level, and we wanted to develop our own strategies within the lab. So we have that cooperative plan, that strategic plan that comes from the Choosing Wisely committee, and each of the different departments created their own strategy so that they were in line and would be more successful in the implementation. And within that strategy, you can see the 4 pillars that we were working with. In one of those, you can see here was improve quality and operation. It's really clear here, the proper use of resources and choosing wisely perfectly fitted here. And Karen already showed this. She showed many posters, and she was saying more is not always better. And this is the one that we came up with. No, if you're eating a hot dog, you don't want to have all that mustard, right? It takes away from the experience, from the good experience. So I wanted to show you the journey over this last 7 years has been like, since the inception of the campaign, since the arrival of the campaign and the initiative up till now. And how have we done it compared to other hospitals, just to show you the success of other entities. This has been the campaign. Each thing that each year, every year, this happened in different departments, in the x-rays, in image department, in pharmacy, and everything else, all the other departments. As you know, 70% of the decisions are based on the lab results. And if you see the recommendations from Choosing Wisely, most of them are linked to imaging and lab. Most of those, 30 or 40%, are embedded in different lab areas. So it's very important that the lab was included. And I was honored to be part of this effort and to lead this effort in the hospital together with the multidisciplinary team, with the support of Wendy and Karen, obviously at a national level. So I just wanted to tell you 2 examples. The first initiative, one of our first proposals was to use creatinine as the preferred indicator for kidney assessment. We've seen that in the literature, and we wanted it to become an exclusive, and we saw that the bond was used for only specific cases. So what we did was find stewardship, so find physician that is a champion of the concept, that he was a champion of the benefits and the risk of assessing and evaluating, examining the patient if you have both of these indicators. So we find a leader of the emergency department, joined with the internal medicine department. We worked together. We worked hand in hand, the lab with these 2 services, and we started to collect data on who were the most frequent patients, under which conditions they were being tested, and under which conditions should the both indicators be held. So for this discussion, we invited not only these two leaders and myself, we had constant meetings with different services, with the emergency room, pediatrics, internal medicine, a lot of areas, a lot of services that were using these indicators. So we asked them under which conditions should both indicators be used, and out of those lists, which you only needed creatinine, and this is what happened. This is a work that didn't simply happen overnight. This has been a work that's been working for many years, a lot of discussion, keeping an open mind and having a lot of flexibility, but also keeping close surveillance and monitoring. So in 2016, when we started these discussions, we were doing 6,000 tests of creatinine with urea. And this point here, after more or less 7 months of having these discussions with multiple teams of different, from different services, from different disciplines, we came to the conclusion that we could remove the orders for BUN from certain clinical conditions that we had it in the system, and we could remove them from certain guidelines that were in the emergency department, because we knew that in the emergency department, 50% of the tests came from emergency. So we knew that if we work closely together with the emergency department, we knew that we could have half of the campaign advanced, right? And we could improve the use of the resources, right? And improve the care of the patients. So we knew that if we did this work, it was had an impact on the patient. So we removed those orders. So those medical directives, we only leave the ones that we thought that were necessary. And we saw a reduction in BU1 tests. The constant meeting with the committee, we realized that emergency department needed to implement it again for certain conditions. They came back. It's important to be flexible. It's obviously everyone had to argument why should this would be. But what we saw is that there was a slight increase, and we stayed at on that level, and we saw that reduction in unnecessary urea tests. And here I just wanted to share this cartoon because I found it really adequate and I thought it was funny. But this is another example where you can work with as well. In pathology, we use indicators for inflammation and for infection. And hematology department, these two tests, those are ESR and PCR. Sorry, the C protein reactive is CRP in English. So it's not PCR, it's CRP. Those two indicators were constantly asked in the hospital. And I know that a lot of hospitals do it concomitantly to assess these two conditions. And we again did the same proposal that the CRP became the primordial indicator for these two conditions. So we collected the data, volume statistics, and we saw who was using it the most. And we did a lot of research. We look into the literature, and what we found, if you take it 4 hours after initial we saw variability depending on sex, on temperature. There were a lot of conditions that you cannot control, and the CRP would become more viable and would be better. And we consulted a big group from emergency, from pediatric, orthopedics, and with all these groups, this took a little longer, but it was a long, very exhaustive work over a year. We finally reached those approved changes after long discussions with many different services. We reach a reduction of 40% in unnecessary VSG tests. So the conclusion here is that if you reduce the test, how many is the physician going to call and ask to add that that test? That's called adds on. And we saw that there was not a significant change in the adds on. So it was reduced here and here. And here we measured the length of stay in emergency for BUN and for the sedimentation rate to see if condition of the patient would prolong because the physician wasn't able to take the right decisions on time. But what we saw was that there was no significant impact. So it had all that support and we achieved that. So from those two initiatives, out of many that we've done, we also worked in a multi-hospital project with 5 other hospitals from the Northern Toronto region. And we call it the Arctic Project because of the region. We had North York, Markham, Sudfield, South Lake, St. Joseph, and Michael Garvin. And these 5 hospitals came together in this project, in this Arctic project, with a grant, with funding from the government that we were able to access to work conjunctly. Just to know how is it that we could compare stories, right? So it's basically what with the OECD does with other countries, right? So it's just basically getting together and comparing the outcomes and seeing how could we share knowledge and see this share successful stories. And here we can see that North York was one of the most successful in reducing ICU CXR. Here you can see the different statistics, and that allowed us to healthily compete with other hospitals. And Wendy already mentioned this. This was an initiative that was launched at the beginning of the campaign of the pandemic, and the North York Hospital was immediately started to process data and achieve and reach those benchmarks that the campaign had set, so that at least that 65% of transfusion was a single unit rather than 2. And the other ones that the hemoglobin was 80% or less when 80% of the cases would be immediately processed. So we already had a very positive story, and we started working on that to extract the data that we had. And we worked with a physician that was specialist in the transfusional medicine with different nurses from different services where transfusions were happening, like emergency surgery. And we realized in a few months that we had enough weight to send that information and to ask for the recognition at the Ontario level as using blood wisely hospital. And North York General Hospital was the first hospital in Ontario. Nowadays, there are many hospitals that have been linked to this campaign. We had the honor of being the first ones, right, to be acknowledged by the national campaign. And the benefits. So people are always asking me, what are the benefits? How do we use the savings, right? So our focus is not at a cost level. Our focus is at a reduction of harmful actions for the patients. We want to improve the quality of the service and to contribute to the campaign. So the benefits are clear. They're for everyone. So first of all, the contribution of the campaign in general is for the hospital, for the department at a local and at a global level. To generate those discussions between the patient, the physician, and to have a multidisciplinary team, it's a joint goal. It's a goal that everyone has. And the second thing is with the savings, what we were doing with the savings. So we identified those savings and we started to implement new tests that physicians were asking for that we weren't able to use. So for instance, for the TEP, D-dimer, and other things that I would like to bring forth. So reduction in other services. So first in imaging, by implementing a more sensible D-dimer, we cooperated with the reduction of angiotomographies with for patients that had pulmonary thromboembolism. So we obviously saw less harm on the patient. We saw a reduction in harm for the patient. And this hidden blood exam in patients, we reduced the number of fake false positives and the number of unnecessary colonoscopies, which was an unnecessary procedure. So sorry, Manuel, we're a little short on time. So here, thrombophilia, we also did that work. Something similar to what I was showing you, the risk-benefit balance. In every campaign, you have to do that risk-benefit assessment. And what we were mentioning previously, and the keys for success. Just to have this, consider this so that this will become a success in Colombia. And finally here, I just wanted to share some links. I know that you're going to have this presentation will be available for you. And once again, thank you and congratulations to the Colombian team. And to invite all the other physicians from other countries to implement this.
This has been a great experience on real world and how these are implemented in the clinical practice. I think we have enough material to be having a whole discussion with all of our speakers that have been enriching the vision and the knowledge of the implications that this amazingly has this campaign of choosing wisely worldwide. I would like to start the discussion talking about a question that is comes deep down in the reflections in this following term. Karen and Wendy mentioned stewardship. And stewardship, it's a concept that is kind of hard to translate into Spanish. Manuel was using it as the correct use of the resources or the adequate use of the resources. I would like to know what is your opinion if one of the key elements of the Choosing Wisely campaign, if this is a campaign focusing on the quality and not in the cost saving or cost reducing, how can we reconcile the concept of stewardship that you have mentioned before? I'd like you to explain to the audience what does a stewardship entails, which is somehow a diffuse term for the Spanish-speaking countries. And I would like you to help us understanding and whether if there is a difference in the control of cost concept. Wendy, you have the word.
Maybe I can start with that. So I think it's important to start with quality and harm prevention because clinicians, physicians, we all know that we do things that don't add value for our patients and sometimes they're harmful to our patients. And that makes a lot of sense to us. And it is something we can discuss with our patients. Like, is it good to have a CT or MRI of your low back when you have low back pain? Or would it be better to wait for a while? So I think starting with conversations about quality and harm prevention is important. But look what the pandemic has showed us. You know, after this pandemic, every country in the world is going to struggle with the costs of the healthcare of their economy. Like, we've had huge fiscal problems. And we stopped many things during the pandemic. We stopped elective surgeries. We stopped a lot of screening things that we needed to be doing. So when we start up again after COVID, doesn't it make sense to say, let's do the things that are really best for our patients and avoid things which don't add value? That's stewardship. That's setting priorities. Let's get the people who could be having colon cancer screened, but let's wait and let's not do unnecessary preoperative testing. We need to have that conversation. That's stewardship, because our countries are all going to struggle with the fiscal constraints after COVID. And so I think I would encourage you to start grounded on quality and preventing harm. But it is inevitable that we're going to be talking not about cost saving, but on prioritizing high value versus low value care.
I'll just add in one.
Adelante,
Sorry,
Karen,
Ramon.
dale.
I'll just add in one point. The language of resource stewardship, which I used in my presentation, was language that we have on education competencies for training and for students. So that's why we use that language of resource stewardship, because it's a competency that is required of training programs. But, and I apologize for using a term that was not easy to understand or translatable to Spanish, but echo that that's the origin of it. But absolutely agree with Wendy's perspective. And I just think I'll add one other thing, which is that Choosing Wisely has this ability to bring various partners around the table: clinicians, patients, and payers. And the clinicians and patients are coming to the table because of the quality and harm prevention, but the payers will come to the table because they are interested in that rationing of limited resources. So just wanted to add those 2 points. Thank you.
Entendido. Y bueno, no, lo de la palabra de
Great,
stewardship.
understood. And the word of stewardship, I just wanted to make clear, because I know it's a word that is quite common in the English language, that in Spanish, maybe we have to break down the meaning. And I think it's quite clear. But Manuel, from your experience in your practice as frontline worker, what is that exchange of not doing certain things because it is not a stewardship of resources and they don't add value? And how do you actually achieve to relocate to other activities in the same frontline in which you are working on, which such resources actually have an added value for the patient? Or do you just contribute to relocate resources to other areas of the hospital or even to other areas of the healthcare system to have a better use of such resources that now you are not wasting, so to say? Is it important to do this exchange in the front line, or you just can cope with the fact that this reallocation will be dealt in other levels? Okay, great. Thanks for such a good question. I think it's both things. When we identify one type of procedure, medication, or a laboratory test that it is not adding value to the treatment and the patient management based on recommendations from Choosing Wisely based on clinical evidence, we can reduce or eliminate this potential procedure or whatever it is, or a medication. So we are first identifying something that is positive for the patient, that goes in line with the clinical evidence, scientific evidence, the Choosing Wisely principle, and in the same time, we use that we have identified within the hospital. We can also use it in the department or to support other Choosing Wisely initiative that is needing to create and to generate a better quality standard or a better implementation of a service, a new treatment, or a new procedure that is required to be implemented within the hospitals. We have a budget within the hospital. Each hospital has a budget, and what we are aiming to in here is to have such budget that you can be using it in an effective manner with a better added value. You can use it within the same areas that you can share with. Okay, it's a good pragmatic way to bring down to our this stewardship. Okay, so now I want to move forward to another topic, which is the professional values. And Wendy is a great authority and an expert. And here within the same type of on how we think as the conception of the campaign, we have a fundamental element, which is the autonomy, the medical autonomy, and how the doctor is autonomous to be able of the decision making on behalf and on favor of the patient. In fact, the recommendations are so-called recommendations are not a must, and the doctor is not obliged to do so. So within this respect, due to the autonomy of the doctor and the fact of proposing these recommendations, which doctor may or may not apply in one or another patient, to what extent is this respect to the autonomy a factor that implies a lack of adoption on behalf of the doctors, and maybe they say, okay, these recommendations are interesting, but I'm not interested in, and I'm not going to follow them. So how have you seen? First of all, I would like to listen to Wendy on what does she think on this regarding the professionalism, and how have you seen if this has actually occurring, happening? And if this is happening, how have you been able to overcome this skeptical barrier?
So I think it is very important what you said, that these are not like musts. They're things that you should discuss and think about. So, you know, I think for physicians who do things automatically, you know, I always ordered 2 units of blood. Now I think, well, should I order 1 unit of blood? It's to question whether these are good practices, or to talk to patients about whether they need it or not. So we're not saying that, of course, clinical judgment always comes first. In that particular case, it might be indicated, or maybe it's not even indicated, but the patient cannot be reassured without getting that test. So you use your judgment in working with the individual patient. But overall, I think when you as a group make these recommendations, you are the peers. You know, if I'm a cardiologist and all the cardiologists say we shouldn't be doing echoes in people who are asymptomatic, then I don't want to be an outlier in my profession. That's part of my identity, to be a good doctor and to follow guidelines. And I think people inherently, doctors want to do what their profession says is best. And then I would just add, it is extremely powerful if you are able to give doctors feedback, what we call audit and feedback. If physicians get feedback on their own practices compared to peers, it is very motivating. So for example, we've done quite a bit of work giving doctors feedback on their antibiotic prescribing in primary care compared to colleagues. But there's a lot of this going on in different areas. Gastroenterologists getting feedback about their endoscopy in certain circumstances compared to peers. And if I see that I'm an outlier, that other people are performing better than me or doing something less than me, less frequently than me, it makes me kind of go, well, maybe I need to change. So I think there's a huge value in the sense of our peers saying what is good practice, and that we are all motivated to be our best. If someone's doing it better than me, I want to improve, because we're competitive in a good sense for our being good doctors. So I hope that sort of answers.
Excelente respuesta, Wendy. Porque
great answer, Wendy. And it's what you've been stated is telling us, and it's quite clear to us, that these kind of recommendations and the way in which they are implemented and they are brought to practice is totally compatible with the principles and the values of the medical professionalism. The, how to say, the control or the accountability to your peers and to be received by the peers, it provides the power and legitimacy to all of this value of medical autonomy. Manuel, would you like to share? Yes. To add to what Wendy has mentioned is exactly what we've done in our hospital, where those exams, those tests that we needed to eliminate, we shown through data, through information for doctors. And we had the 10 users that were the most important users from thrombophilia, which were like a $500 test, the whole workout. So we just shown that the most frequent users, we talked to them, we shared the data, we shared to them, to the whole team from that area, from hematology, so that they can all reflect on that. And maybe who wants to be left behind? Nobody, right? So in the same sense, the guidelines that supported this information. And on the other thing I wanted to share is that we have to listen. And I'm saying this because we also had the experience that through eliminating some exams, some tests in some areas, the time to being an inpatient was delayed. So when we realized that, we went back on and we were flexible, we had a multidisciplinary team discussion and we had to go back on and implementing such a test. Right, excellent. Karen, I would like to ask you on, because we have a question from the public, but also from the presentation that you shared. There's still the question on the empirical evidence that goes beyond the graphs of control charts from the cycles of PDSA in English. This evidence of the cycles from planning, doing, studying, and acting is an evidence that is provided or is built from before and after of a practice or an implementation, as Manuel was showing and Wendy and Karen. But also, for example, there is not a control group. We were not assessing other centers, probably of intervention at the same time, and we compare against a control group. So to what extent do we have an evidence on such a type of a robust and a general evidence, or what is the type of evidence that we have built from this kind of intervention? It's just based on the improvement cycles localized in the hospitals.
So Wendy, feel free to chime in. I'll give a brief response.
Por supuesto, claro.
Yeah, there is, a really growing, I would say, Choosing Wisely in the United States, as you described, Ramon, launched almost 10 years ago. And there's a really large body of research evaluating some of the hospital-specific interventions that Manuel spoke to. It's very hard to, look at some of these big picture measures over time. We are doing some of that measurement in Canada. So we are working with our national Health Information Institute to try to have some longitudinal data associated with the campaign, but it's very difficult to say that the Choosing Wisely campaign in and of itself, drove changes to some of these system level measures. But what we are trying to do with some of the implementation work that we've been launching is to try to support that and bring those PDSA and quality improvement methods, audit and feedback, and some other quality improvement tools to more of a national level to move some of the demonstration projects that we've seen that use these methods at an organizational level up to the system level. Wendy, do you want to add in more on that?
Yeah, I'll just add, of course, it's hard sometimes to say, well, how do you do this in a way that's rigorous enough, like to publish? But sometimes even within a hospital, people have done trials where they implement on some wards, but not on others. So for example, a lot of the folate, we looked at reducing the use of Foley catheters. And that was mainly kind of directives to the nurses. So they studied it by implementing it on some wards, but not on others, and showing that the rates of Foley catheter insertion fell on those wards. Another method, if you are doing multiple hospitals, is to do what's called cluster randomized trials, where you randomize and then have some hospitals enter sooner and others later. And you can use different methods to have more rigorous assessment of whether this intervention was really the cause of the decrease. So I think it's challenging within one institution, it's challenging, but I think that there are growing efforts to do it in a more rigorous way. And if what you can do is just PDSA cycles and you can't be 100% certain that it's due to the intervention, well, that's okay too. If you're starting to see that decrease, if you can compare it to a different ward or a different hospital, so much the better.
Bien, creo que ese es un reto que nos
Great,
queda.
I think this is a challenge then that we have to implement in the Colombian initiative so that we can be able to have somehow an empirical assessment and corroboration so that we have a randomized cluster study. It's a good recommendation as well. And I hope that from Colombia, we can be able to contribute to the growing evidence of the choosing wisely impact. Unfortunately, we're running out of time, and I think it's been such an enriching presentation. I hope our audience has perceived the impact it has and the power this campaign has worldwide, and the pride it is for us as Colombians to be part of this initiative that is a global initiative. We have a lot of work ahead to do. And as a moderator of this session, I just want to thank you, three of you, for your excellent support, the energy and the positive energy you have provided to us. And I want to give the floor to Dr. Lina Triana for the closing session. So my apologies to the audience because we were not able to bring up all of the questions, but due to time constraints, we have to close. Once again, thank you, everybody. Thanks for being present in here. Thank you for the pioneer societies that are actively developing the exercise. And of course, to the whole team of Choosing Wisely International as the chair with Dr. Levinson and Dr. Karen Bourne, as well as Dr. Firaldo, to support us throughout this whole process that is just starting. And once again, I don't want to stop thanking you for the whole team that is making this possible. Patricia Torres, that is helping us, and the whole pioneer societies, and of course to Abel, that has been able to carry out this forward. Scientific Society is the channel to develop this, but Dr. Ramon Abel Castaño is the manager and the promoter of this to be happening today. Thank you very much. Dr. Abel is your microphone. Good afternoon, good evening, everybody. Bye-bye. Thank you.